So it is my privilege to introduce Professor Ishwar Singh. Professor Ishwar Singh is Director Professor at Maulana Azad Medical College and Associated Hospitals. He has interest in head and neck cancer surgery, uh, apart from all the other fields that he works in. And he has about 100, more than 100 publications to his credit. Apart from the ENT qualifications, he has also done an MBA in hospital administration. And sir will be talking today about radical neck dissection. So, sir, please start your talk.
Good evening, everybody. Thank you. Am I audible, Nilima?
Yes, sir. Yes,
Ah.
sir.
Good evening, everybody, and thank you, Nilima, for and this in calling me for this auspicious occasion to address all the students. So today I shall be talking about radical neck dissection, and it is one of the major operations of the head and neck. And I shall be talking what is various terminologies. I'll be taking you through the history, through the indications and the various terminologies which has been used. So this is the topic for today. And history of neck dissection is very interesting. So it dates back way back to 1847, when this Joseph von Chelius, he gave the concept of cervical lymph node metastasis in the neck cancer, or in any other cancer, even in the abdominal cancer it started. Then the second most important person is Cocker, and the Cocker artery which you have been using is devised by this person. And another peculiarity or this thing is that this person or this surgeon, he had been given Nobel Prize for maximum thyroid surgeries. He was a general surgeon, and he operated this carcinoma tongue, and in that he removed the submandibular gland, and that was one of the early part of the neck dissection. So the next most important person who actually brought the concept of radical neck dissection is Javodensky, and he was a Polish surgeon who actually described the this neck and radical neck dissection, and but he published his paper in the Polish journal, and which had very less circulation, so it didn't come to light. It was the Cryle, George Washington Cryle, who is given the credit, and he published his paper in English literature way back in 1906, and all credit goes to this Cryle. And majority of the people think that it is he who started, but it was Jondensky who gave the exact description, but it was in a Polish journal. Hayes Martin from America, he was the chairperson of Kettering Hospital, and he devised even incision, and he was one of the strong proponent of the head and neck and this radical neck dissection in head and neck cancer. He is Soros is the first to devise the functional neck dissection. He was an Argentina surgeon. As we see in ear surgery, the radical mastectomy was modified, so was neck dissection was modified. The structures which are not involved, like spinal accessory nerve or internal jugular vein or sternocleidomastoid, why should they be sacrificed? So they thought that remove the lymph node and including the structure which is involved and spare the structure which is not involved, and that led to the birth of modified neck dissection. And this Boca, he was from this thing Italy. He was also a strong proponent of functional neck dissection. It all happened because the spinal accessory nerve complication or the subsequent effect of removal of the spinal accessory nerve was so it was leading to morbidity, and to prevent that morbidity, these people thought of sparing the spinal accessory nerve if it is not involved. And these three persons, Soros from Argentina, Boca from Italy, and Gavelian from Spain, they adopted and popularized this functional neck dissection or modified neck dissection, in which all the lymph nodes from level 1 to 5 have been are to be removed and spare the spinal accessory now internal jugular vein or the sternocleidomastoid. These are non-lymphatic structures which are removed in radical neck dissection. With this, I just want to refresh your knowledge of the lymph nodes of the neck. It was in Sloan Kettering Hospital in New York that these levels were first talked about in middle of 60s, and it was devised or propagated by a resident. So exactly who did it, nobody knows, but as we know by our anatomy or by our knowledge of ENT or head and neck, these neck nodes have been divided into 7 groups. The first is from the first group is further divided into A and B. First A is between the two bellies of the digastric, and it is lower. This triangle, anterior triangle, it is between the two digastric of the digastric bellies, and a lower boundary is formed by the hyoid bone. And this 1B is between the anterior posterior belly of the digastric. This level 2 is again divided between 2A and 2B by a long axis of the spinal accessory nerve, and this 2A is from the posterior belly of digastric to the level of hyoid bone. That it is in the upper 1/3 along the upper third of the internal jugular vein. Level 2 is between the hyoid to the cricoid, lower border of the cricoid, and it is in the middle of the internal jugular vein. And level 4 is from the lower border of the cricoid to the level of upper border of the spinal and clavicle. Level 5 is in the posterior triangle. It has again been divided into 2 groups, level 5A and 5B. 5A, it is divided again, a horizontal line is to be drawn at the lower border of the cricoid. Above this is level 5A, below that is level 5B. And level 6 is from the hyoid to the suprasternal notch, and it is in between the middle wall of the carotid vessel. So it is the central compartment. And level 7, that is below, it is here in the mediastinum, and the lower limit is arch of aorta and bounded between the common carotid artery or brachiocephalic artery on the right side. So these are the levels, and this is important to know where to which level is to remove in which condition. In radical neck, we remove all the level from 1 to 5, because head and neck cancer, it is so in oral cavity, the this level 1A and 1B are commonly involved. That is especially in the oral cavity, floor of the mouth, tongue, or anterior nasal cavity. All these nodes, they drain into 1B, 1A and 1B, and even this 2A is most important group. It is also involved in this, but majority of the nodes are drained in the level 1 and 2. So in a study by Lindbergh, in which he had 787 cases, and he found that in 42% of the cases, this level 1 is commonly involved in the floor of this oral cavity malignancy. Especially the 1A is involved in the tip of the tongue or anterior part of the floor of the cavity. The other nodes which are involved is level 2A and 2B in 79% of the cases. In level 3 is involved in the oral cavity, nasopharynx, oropharynx, and hypopharynx. As we go posteriorly, the lymphatic drainage goes in higher level of the lymph nodes. As in the oral cavity, it happened in the first group or in A, and in oropharynx and oral cavity, again this level 2 was involved. But as we go posteriorly in the nasopharynx or oropharynx, the lower level of the lymph nodes or majority of the nodes are in level 3, and level 2 and 3. And these other groups like level 4 or 5, they are less involved as compared to level 2 and 3. This level 2 are involved in majority of the cases. So this is the most important group of nodes, and you should know that they are the one in which all the nodes are, all the cavities are drawn, and you will be seeing that level 2 is removed in almost all cases. Either it is selective neck dissection, or in the omohyoid, supraomohyoid, or lateral neck dissection, or posterior neck dissection, because these are the most important group of nodes which are present in the upper 1/3 of the neck. Now, this level 4 is again involved in the tongue, and I'll be talking about the skip metastasis. Level 4 is the one which is not involved usually in the oral cavity, but there is a skip metastasis in which the routine level is not formed, and it bypasses the level 3 and gets metastasis in level 4. So in that, especially in the tongue, the lymph nodes come early in the tongue, because the tongue is the most vascular structure, plus it has a higher mobility, and there is a pumping effect of the musculature of the tongue, which leads to early lymph nodes in the cases of tongue. So this level 4 is involved in thyroid, cervical, esophagus. Now coming to the terminologies, comprehensive neck dissection means lymph node removal from level 1 to 5. Selective neck dissection, when we move less than 5 levels, one or more level is left behind or preserved, which is not involved. So we should know where the nodes or which nodes are drained in the oral cavity, which nodes are involved in the oropharynx. So we should know the majority where the or which is the commonly involved nodes. In radical neck dissection, we remove level from 1 to 5 and spare the spine and remove along with this spinal accessory now, internal jugular vein, and sternocleidomastoid. These are the non-lymphatic structures. In modified neck dissection, again level 1 to 5 are removed, but preserve either lens or spinal now, or internal jugular, or because this spinal accessory now, it has lots of morbidity, so it must be preserved unless it is involved. So the definition of radical neck dissection is neck dissection is a surgical procedure to remove metastatic ipsilateral cervical lymph node groups. Superiorly, it is below the margin of the mandible, inferiorly up to the clavicle. Contralaterally on the anterior belly of digastric muscles, because level 1 is in the midline, so it is up to the opposite side digastric belly, which is to be included, and in the midline it is the lateral border of the sternohyoid muscle, and posteriorly it is up to the anterior border of trapezius. So, and in this tail of the parotid is also included. So level of the nodes which are removed are 1 to 5, including this non-lymphatic structures, spinal accessory nerve, internal jugular vein, sternocleidomastoid, and nodes which are not removed are post-auricular, suboccipital, retropharyngeal, buccinator, periparotid. These nodes are not included, though they are present in the neck. Indications for neck dissection are significant operable node which are in the level 2A, 2B, or 3 with primary tumor in the upper aerodigestive tract, or there is an extensive involvement of these non-lymphatic structures, that is spinal accessory nerve, internal jugular vein, or sternocleidomastoid, or it is also be done as a salvage surgery, or when the earlier treatment is for the extensive recurrent disease, when the previous disease was, or the treatment was selective neck dissection, or the primary treatment was radiotherapy, and there is a failure of radiotherapy and patient has either residual or recurrent disease. So again, you have to resort to the radical neck dissection. Or it may be done in some of the cases where you have to do a repair and you have to take a pedicle flap in that you remove the sternocleidomastoid, this muscle, just to make a space for the pedicle flap to come up. Or it is also done when you have unknown primary. In that, you have tried to look for primary everywhere. The common sites of primary, occult primary are the base of the tongue, tonsil, nasopharynx, especially the fossa of Rosenmuller, and the cervical esophagus, apex of piriform fossa, and thyroid. These are the common sites where you have occult primary or unknown primary. And giant cystic hygroma is one of the non-malignant indication where you may have to resort to removal if the sternocleidomastoid or these spaces are involved by the cystic hygroma. You may resort to neck dissection. So it will not be a proper which is done for the malignancy, but it will be more of modified neck dissection. So that was a radical neck dissection. Now we have extended neck dissection, and in this, apart from those structures which I have just told you, you can remove additional lymph nodes like retropharyngeal nodes or the skin, or if the hypoglossal nerve is involved, or even if the carotid, external carotid is involved, that can also be sacrificed, and this then becomes extended radical neck dissection. Contraindication are if the primary is unresectable, then what is the fun of doing a neck dissection? When you can't remove the primary, so you can't go ahead with the neck dissection, or the nodes are so adherent or you are not able to separate them, and if it is encasing the internal carotid artery, or they are attached to the brachial plexus or prevertebral fascia, then these are not the candidates for neck dissection. Or patient is not fit for surgery. If the general anesthesia cannot be tolerated by such patient, you can't do neck dissection. The other contraindication is if the patient has distant metastasis either in the lung or in liver or in the bone, then again there is contraindication to carry out neck dissection. The structures which are, as I said, the various, this is the inferior border of the mandible, anteriorly up to the sternohyoid muscle. Lower down, it is the clavicle. Up to the clavicle, you can see the sternocleidomastoid is moved, and this is the vagus. All the carotid vessels, internal jugular vein, spinal axis is now which has been removed, and posteriorly it is the anterior border of the trapezius. So these are the structures which are left behind, and this is the picture diagram of the radical neck dissection. And these are the nodes from 1 to 5. These are nodes which are removed. Now, as I said, this radical neck dissection leads to lots of morbidity, and these surgeon from Boca from Italy, they propagated this functional or modified neck dissection. In this, all the nodes, there is no compromise on the level of nodes. 1 to 5 nodes are dissected out, and the dissection is again below the mandible up to the clavicle, anteriorly up to the lateral border of the sternohyoid muscle to the anterior border of the trapezius. So these nodes are the same, but you preserve either the spinal accessory nerve, internal jugular vein, or sternocleidomastoid. And the spinal accessory nerve preservation takes care of all the shoulder problems, and internal jugular vein, when spared, because when you ligate one internal internal jugular vein, then the intracranial pressure is raised by 3 times, and when both are veins are tied, then it is raised by 5 times. So the ICT intracranial pressure is not raised when you spare the internal jugular vein, and you still carry out or remove the nodes in functional neck dissection. So we get the result of removing the disease part, and the functional part is preserved. So the indications for modified neck dissection, when the level 1, 2 and 3 they are involved and not involving these 3 non-lymphatic structures, so that is a straightforward. Or if you have to carry by bilateral, again you are sparing the internal jugular vein, or this internal jugular vein is preserved if you have to carry out the microanesmosis. Nowadays more of the radical and this free flaps are done, so we preserve the vessels, draining vessels for the flap to be anosmosed to the common facial vein, that is the commonest site where the vein are anosmosed. And there is a not involvement of these structures, so again these are the candidates. The contraindications are again the same what I said in neck dissection. If the primary is not resectable, or patient is not fit for surgery, or patient has distant metastasis, so no need to take up such cases. So in modified neck dissection, again the level of dissection has been seen. You are preserving the sternocleidomastoid, internal jugular vein, and spinal accessory nerve, and the nodes which are removed are level 1 to 5. So it's serving the purpose and sparing the functional part. So it has been divided into 3 parts. When the internal jugular vein and sternocleidomastoid muscles have been are removed and the spinal accessory nerve is preserved, so it is type 1 modified neck dissection. In type 2, the internal jugular vein and spinal accessory nerve are spared or they are preserved, and sternocleidomastoid muscle is removed, and is type 2. In type 3, when all the 3 are preserved, you can see this is a modified neck dissection. This is the sternocleidomastoid muscles, this is spinal accessory nerve, and this is internal jugular vein which has been preserved. So it is type 3, and we are removing all the diseased lymph nodes or all the nodes which are involved. So this is modified neck dissection. The selective neck dissection, as I said, in this we remove only the nodes which are draining that site, and that is the selective neck dissection. The supraomohyoid level, the oral cavity is the commonest site, and in this level 1, 2, 3 are involved, and then the submandibular gland is removed. As I said, there are chances of skip metastasis, and it happens in almost 12 to 15% cases. So in that, you have a node which is harboring the disease. So in that, we do a extended supraomohyoid neck dissection, and in that level 1 to 4, along with the submandibular gland, are removed, and all other structures are preserved. In lateral neck, especially the hypopharynx or piriform fossa, or in supraomohyoid neck dissection is the, and these are the level 2 to 4 which are the commonly involved, are removed. And in central neck compartment, as I told you, from higher to the superior border of the suprasternal notch, and laterally between the 2 carotid vessels, and the nodes which are removed are level 6, and these are parathyroid, Delphin node, that is preprecardial node, and this can come as a MCQ. And this structure primary from the trachea or esophageal part, these are the sites from where the primary will come, and these are removed in central compartment. So selective neck dissection who risk early lymph node metastasis and block removal of one or more group which are primarily involved, and we have to know the pattern of spread of the disease in an untreated neck. So this, if the patient has undergone some treatment like in the form of radiotherapy or some selective neck dissection, this thing, then the pattern of spread of this node will be different. So we should know which are the nodes which are at high risk to carry out this selective neck dissection. There is another term which has come. There is not much of literature or a thing has been done on this super selective nodes. In this, we remove only 1 or 2 continuous level of the nodes. Like I will give you an example. Say there is a carcinoma tonsil. You have tonsil has responded, but there is a level 2 node, which are the node of the tonsil, which are not responded, or there is still residual tumor which is left behind. So you can do a super selective nodes. So you remove that level 2 or 3, and then the other nodes are not disturbed. So the positive nodes after surgery or adjuvant radiotherapy is added in this. If you have done a say neck this, say you are doing a primary removal by surgery in case of laryngectomy, and you feel that during introp you feel the level 2 and 3 they are enlarged or they are palpable or they are bigger, and you subject them to a frozen section, or you send them for histopathology as a specimen and they come positive on histopath report. In that, the adjuvant radiotherapy can be added. So this is a newer term which has come into existence, and when this radical neck dissection was classified, so this super selective neck dissection was not there. So supraomoid neck dissection, it is done in case of squamous cell carcinoma of the oral cavity, and it can be done bilaterally, especially if the tip or the floor of the mouth, both the sides can be involved, or skin cancer which are extended from the tragus, so extended supraomoid can be done. And again, this is involving the ventral aspect of the tongue or the floor of the mouth. These are the indications where supraomoid neck dissection is done. In case there contraindication is when there is inadequate oncologic clearance or patient is unfit, or if there are 2B nodes are positive, then you have to do this thing, modified neck dissection, because that is not usually removed in supraomoid neck dissection. These are the pictorial description from the mandible of this to the anterior border of sternohyoid muscles and posterior border of the sternocleidomastoids, and so it is the omohyoid. So it is above this, and in extent, and these are the nodes which are removed are 2, 1, 2, and 3. These are the generally or commonly involved, but in case of tongue, as I said, these are in tongue you have a chance of skip metastasis, so level 4 is to be included. Otherwise, in 20% of the cases, level 4 is involved and bypassing level 3. So you have done a neck dissection, supraomoid neck dissection along with the primary, but in 20% of the cases, level 4 is positive and you may still live behind the disease, and this will not be beneficial for the patient and neither for the surgeon. So lateral neck dissection, especially for the oropharynx or hypopharynx and in the larynx, and tumors which cross the midline. So this can be done bilaterally, neck dissection. So again, the contraindications is you can't clear the primary, or patient is unfit for the major surgery, or patient has already distant metastasis. So then you don't give a radical cure or proper treatment to the patient. So such patients are unfit for neck dissection. So the nodes which are removed are level 2, 3, and 4. In the central compartment, as I said, starting from the hyoid to the suprasternal notch and in between the two carotid vessels, the tumors or the sites which drain there are subglottis or hypopharynx, medullary carcinoma, differentiated carcinoma, that is follicular carcinoma, or and this papillary cell carcinoma. So clinically, these nodes are not, say you get a case of CA thyroid on FNAC, it is papillary cell carcinoma, and you are planning to do a total thyroidectomy. So you have to do, along with total thyroidectomy, clear the central compartment. So these are the sites from where the primary can come, and you have to do a proper job. And the other side which can throw a secondary is from the cervical esophagus. So again the contraindication are same: patient is unfit or distant metastasis, or you are not clearing the primary. These are the sites from where the you have to remove from the medial side of the this vessel up to the sternal suprasternal notch, and from head to the other side. And level 6 are a separate group of nodes. Posterior lateral, it is the indications are malignancies behind the posterior margin of the ear or cutaneous malignancies. These are the usually skin cancers, melanoma, and especially pinna, or in the post-oral region, the malignancy and the squamous cell carcinoma is there, and there can be cases of soft sarcoma, which can also be in that the posterior lateral, because this area behind the pinna and posterior scalp drains into these level 2 to 5. So only those nodes. So no fun or no point in removing the level 1A, because that is the site which is rarely involved, and the contraindications are same as inadequate removal of the primary, unfit for the major surgery, or you have a distant metastasis. So nodes which are removed are level 2, 3, and 4 plus level 5. So with this background of the lymphatic, I'll just tell you the blood supply of the neck. The skin gets supply from the facial artery, and this is superior thyroid artery, and this is thyrocervical trunk. This is the transverse artery and superior scapular artery. So these are the vessels, and superiorly this posterior occipital artery again branch of external carotid. So you get a blood supply lower down from the thyrocervical trunk and upper from the external carotid. There is no branch of the internal carotid in the neck. That fact you must remember. And these are the vessels. So the incision should be planned in such a way that it doesn't cut the major blood vessel which are supplying to the flap, and these have to be preserved. So entirely starting from submantis, going to the heart, going posteriorly to the mastoid tip. So in this way you are preserving the facial artery, and this occipital artery branches are preserved. So you have maintained the blood supply to the superior flap. And then this Y should come posteriorly. It should not align with the axis of the carotid vessel. So you should place the vertical flap posteriorly in a avascular region, so that the vascularity is not compromised. So these are the factors which should be considered when you are planning the incision. So I'll be talking about this. The position of the patient is supine and extended, and these are the structures which should be exposed: the chin, the ear lobule, the mastoid process, clavicle, and the suprasternal notch. They should be exposed when you are cleaning, draping the patient. The cleaning and draping has to be done from the oral cavity or right up to the maxilla, up to the nipple line. This is the area which is to be prepared for a neck dissection. And depending on the primary, where it is present in the oral cavity or in the larynx or in the pharynx, and then if the primary is in the hypopharynx or in the larynx or in the thyroid, then oral cavities or the face can be covered up. But if the primary is in the oral cavity, then you have to keep the mouth or the angle of the mouth exposed, so as to orient yourself, and you can do the primary resection when you have finished the neck dissection. So and the cleaning and draping, incision planning, I'll be talking in detail. The flaps will be elevated, and then the sternocleidomastoid muscle is resected, and ligation of internal jugular vein and posterior triangle dissection is to be cleared, and then you do the superior dissection. These are the few of the steps of the neck dissection. So this is the patient. Patient is kept supine, and these are the area which are marked. So it is cleaning has to be done right up to the maxilla to the nipple line, because you may have to take a flap or do some repair and reconstruction if oral cavity or the is involved, or you may have to take a pedicle flap, or if the free flap is involved, then those plastic people or your other team will come and they start harvesting the flap as per the requirement. So the neck is extended, rotated to the opposite side, to the side which you are opposite to the neck which is involved, and it has to be extended by keeping a sandbag under the shoulders, and the head end of the table has to be elevated by 30 degrees so that the bleeding is less, and there will be help in the prevention of blood loss, or you will get a better hemostasis or a better dry area and dry field. So these are the landmarks which should be kept: chin, mastoid tape, ear lobule. So nothing new. So incision planning is, it has to the plan incision in such a way that all the nerves which you intend to remove are exposed. Preserve the blood supply to the flap, as I said when I told you the vascularity of the neck. The flap should be broad based so that there is no chance of necrosis, either superior or inferior base. If it is superior base, then the facial artery will take care, and there should not be no trifurcation. Try to avoid this trifurcation as far as possible. So the incisions which are hockey stick or boomerang or McPhee, these are the commonly practiced incisions. So this should provide an exposure, and it can be modified to include the primary. I'll show some of my cases. And if additional node which you intraoperative feel needs to be removed, then that can be modified to include those nodes. And in case you feel there is bilateral, then modify the modification to include the other side should be there. And there should be minimum complication in the form of avoiding the trifurcate incision or the carotid, and there should not be tension when you are suturing, and aesthetically it should be acceptable to the patient. So these incisions have been divided into two types: trifurcate and non-trifurcate. The commonest, which is trifurcate, are Cryle, Cocker, Martin, Slaughter, Schaubinger, Conley, modified Fraser, half H or horizontal T, and front incision. The non-trifurcate are apron, which is practiced for this neck dissection. McPhee is a separate two horizontal. It is also known as stepladder incision. J-shape, hockey stick, they are more or less similar kind of. Boomerang, I'll be showing you in one or two cases of mine. And modified apron is same when you give an incision for the neck dissection, this laryngectomy, and drop a vertical limb from the curved part to the suprasternum, this midpoint of the clavicle, and one of the limb of the apron incision is taken to the mastoid tip. That is usually done with the laryngectomy with neck dissection. So this is Cryle incision, starting from the tip of the mastoid to the this mandible, and it is horizontal at the level of, I mark this hyoid bone, and then at the midpoint to the midpoint of clavicle, and it is made a curvature so as to prevent the contracture. It gives a good exposure, but the problem is trifurcation is there. This point is and 3-point junction is there. You can't help it, because I've been brought up and I've seen surgery in this, so I prefer to give this incision. Then his Martin single Y incision is again something similar what Cryle had given, and it is a good exposure, 3-point junction, scar formation, and there is difficulty in dissecting the subclavian area. Only is again similar Y type of incision, but it is 2 to 3 centimeter away from the mastoid process and goes posteriorly beyond the sternocleidomastoid mastoid. It has a good exposure, 3-point junction, that is there in all the Y shaped incisions, and star contracture, again it can be there. There can be keloid formation. Schaubinger, he placed more posteriorly and more horizontal, and so that the anterior flap is bigger, so as to cover all the carotid vessels which are or the vessels internal jugular or the carotid which are there. So that is the only, and it is broad base. Modified this vertical he modified into S shape so as to prevent the contracture formation. Otherwise it is same as that. So that is the only modification. Half T, this I gave in case of carcinoma, papillary cell carcinoma of the thyroid. So this horizontal is the limb which is given for the thyroid surgery, and this vertical was for the neck dissection. So you have a broad-based superior flap, though usually in a standard incision which you saw, it is at the level of. So you have to tailor-made to the patient as per your requirement. It is not that you have to give this one standard incision. So one shoe doesn't fit all. So here we got a good exposure, and though there is a 3-point junction, you can't help it. So this McPhee incision, earlier the radiotherapy was given as the first line of treatment in the cases, and if there is a recurrence, so you have a step ladder incision. So there are 2 steps, and this is a bipedical, so there is a double blood supply. This flap has a supply from both sides, and so the it is cosmetically well accepted. It is in the crease. The incision is from the suprasternal notch, 2 finger away from the below the, above the clavicle, and again in the same standard incision starting from the submentis going up to the heart to the mastoid tip, and lower down it, as I said, 2 finger above the clavicle. So these 2 horizontal incisions are given, and it is specially meant for the post radiotherapy cases, because post radiotherapy the wound healing is delayed and there are chances of carotid blowout because of the exposure. So the difficulties with this incision is that there is a limited access. You have to work elevate this flap downward, and then you have to work all the way under the tunnel, because this middle flap you put a gauze piece or a ribbon gauze or this ligature, and one assistant has to constantly retract this flap up and upward, so that the surgeon can work below this. So he has to work under a tunnel, so the vision is limited, and they can be bleeding from the undersurface of this flap, and if they are large metastases, so it will be difficult to dissect out. So dissection is a difficult thing, but for the healing and prevention of post this surgery complications of the are taken care by this flap. Barbosa is a H shape, again 2 to 3-point junction, and exposure is good, just to complete or increase the list. Now these are the non-Y junctions, and again this is a horizontal, vertical limb is again posteriorly placed on the posterior border of the sternocleidomastoid, and this is 2 finger above the suprasternal notch. So it is J shape or hockey stick shape or lateral utility incision. So you have a broad-based flap and exposure is good. Then this is Hayes-Martin double Y incision. Here from the submentis to the mastoid tip, and this is something similar to the McPhee incision. And there are 2. This vertical line is almost usually on the carotids, and the other disadvantage is there are 2 3-point junction, and it is not a good incision, though it was propagated by one of the prominent head and neck surgeon, Sir Hayes-Martin. In case you have to do bilateral neck dissection, especially modified neck dissection or supraomoid dissection, then this is apron incision, modified apron, or bilateral utility or bilateral hockey incision, or this is modified Galex or incision, or bilateral boomerang incision, which you will see in one of my surgery. So this is boomerang incision. As this person had been chewing chewing this tobacco, and this fellow, they keep the quid just below the lower lip, and this is site which is involved. This island of the skin was involved. We could see there was a purely orange, so the skin was involved, and so this flap, this much of the skin is to be removed. So it is midline vertical, and then this is the boomerang incision which is given to do the bilateral neck dissection, and the mandible was anterior part of the mandible was also to be removed. So we did a fresh tracheostomy. You can see in otherwise in a neck dissection the tracheostomy is not to be done. We are anticipating in this head and neck surgery that because the genohyoid muscle and genoglossus muscle will be involved. So in this, the tongue chances of tongue fall are there, and we know this is will lead to the obstruction of the oral and this thing airway. So we did a primary tracheostomy before starting the case. So after that, you can see the fresh wound, and this is the boomerang incision, bilateral, and bilateral neck is to be done. The in this, the this angle of the mouth is involved. So this part, this much part of the skin needs to be resected. So and not the standard incision is done. So this has to be tailor made as per the primary. So in the same incision, we are including the primary as well as the neck dissection, which is done. You can see the same patient. So these flaps are elevated, and this island of the skin and bilateral neck dissection was done. This is case where trial incision starting, and this mandible segmental mandibulectomy is done. So the lip splitting was also done along with this, starting from the mastoid tip to the hyoid, and this vertical limb again into the midline. And you can see the sternocleidomastoid, the spinal axis is now the internal jugular vein, and these are the both the bellies of the this digastric. And the this angle of the mandible below the ramus, it has vertical ramus, it is removed, and now this prefibula graft was put in this, and this angular vein or this facial vein, these are used as a site where the free flap will be anosmosed. So flap is elevated. The flap elevation is just below the platysma, and muscles, subplatysmal flap is elevated. The now which is greater auricular now is not included, preserved in the selective neck dissection. And in case the platysma is involved, then the skin is elevated or modified. And to preserve the marginal mandibular nerve, we have to do a Hayes-Martin. This will be a viva question. What is Hayes-Martin maneuver? It is just to preserve the marginal mandibular nerve. In that, you ligate the anterior facial vein and elevate the flap in with the help of that, and the marginal mandibular is preserved. Again, these are the flaps which are, this is posterior based, and this is superiorly based, and this is anteriorly based. So, and the as I said, it has to be tailor made. The superior flap, as I said, this is the marginal mandibular, and this is the marginal mandibular now, and this is the facial vein. So you tie it here and elevate this, including the flap, so that the now is not damaged. The four areas which are important are this medial part, lateral part, and the superior, where the internal jugular vein comes out from the skull, and this segmental area. So these are the important area which needs special attention. So after the flap elevation, this is pictorial taken from the operative book of Myers. So this is the situation which we get. So external jugular, and this is greater auricular nerve. So you start with dissecting with the lower border of the sternocleidomastoid, and then elevate it, and this carotid sheath is exposed. So this is the picture where you have elevated this. You have dissected the sternocleidomastoid, and then you cut open the internal this sheath and tie the internal jugular vein, and you have to be very meticulous. There should be two ligature at the lower end, one ligature upper one, and in between you have to cut, and you have to ensure that you don't include in this when you passing the ligature, the vagus nerve is to be spared. In the beginner or in the cases where radiotherapy has been given earlier to the neck, these are plastered, so you have to be extra cautious, and this vertical opening of this carotid sheath can be up to 1 or 2 centimeters, so that you have a good exposure, and you have to devote some time to carry out this very important this thing step, and then put a blunt finger and start dissecting the posterior part or anterior border of the sternocleidomastoid and this border of the trapezius, and you have to ligate all the vessels which come in between, and then go up where this you have to cut the upper end of the sternocleidomastoid, you 1 centimeter below the mastoid tip, and then elevate and lift this whole specimen anteriorly. This is the way it looks. You have cleared the posterior triangle, whole fibrofatty tissue is retracted anteriorly, and then you keep on dissecting. These are the cervical branches you come across, and these you try to preserve, and this spinal accessory now which runs is also resected out, and you tie the upper end and internal jugular vein. This is a carotid vessel, and retract the specimen anteriorly. And now you carry out the superior dissection. And this submandibular gland is separated. The facial vein is ligated, and you can see which I was talking about. This is the vein which is ligated, and these are the marginal mandibular nerve, because this will be otherwise lead to the depression of the lip, and patient has a this will be shown on the face when the patient is trying to laugh. One side will be not moving properly. So this is the specimen which you see after the photograph, after the removal of this, all the structures, the sternocleidomastoid, the internal jugular vein, spinal. Now this is the carotid, and this is vagus nerve, and whole of the this fibrofatty lymph nodes and have been removed, and this is the boomerang incision. So this is what we get after the neck dissection. Now I'll be talking about modified neck dissection. We'll be sparing the, after elevation of the flap, you start dissecting from the posterior end of the sternocleidomastoid. So it is the flap which are elevated, and this fascia which is there, which is held by multiple forces, artery forces, and you expose the internal carotid and this vessel and this internal jugular vein. This is one of the patient, my 14-year-old girl who had been chewing tobacco, and this skin was involved. So this was how the incision was worked, and this skin island which was involved was removed, and modified neck dissection was done. And this is spinal accessory nerve which is preserved, and all the fibrofatty tissue which is removed in this case. And this is the specimen after removal of the primary. Same, the segmental mandibulectomy, oral cavity, this thing, and the internal jugular vein preserved. You can see the spinal accessories, sternocleidomastoid. So this is a modified neck dissection. After the neck dissection, what happens to the patient? So if you, when the spinal accessory now is removed, it leads to the denervation of the trapezius muscles, causes destabilization of the scapula, because this is muscle arises from there, and when you lift or try to do something, the scapula gets away from the vertebral border, that is called flaring of the scapula. So there is a winging of scapula also called, and there is anterior rotation of the scapula, and person is not able to abduct the hand about 30 degrees, because the rest of the abduction is of the hand is done by the trapezius muscle, and the angle also this occurs at the upper girdle. So patient of this in whom the spinal accessory now has been removed is also land up with the shoulder syndrome, in which there is a dull ache, pain because of the atrophy, there is weakness of the muscle, and deformity of the this shoulder girdle occurs. The other complications which occur, because if the patient has received radiotherapy more than 70 degrees, the rate of complication increases. If there is a comorbidity like diabetes or poor nutrition or anemia, or in old age the healing process is slow, or if there is a hematoma or bleeding can occur from the upper this thing superior if there is slippage of ligature of the upper end of the internal jugular vein, or there is a bleeding from the face and this thing, or this thing facial vein, or there is injury to the carotid. So all these lead to the bleeding, and this has to be tied intraoperatively. Or if there is a swelling in after you have tied the you have done the suturing, if there is a hematoma formation, then that hematoma can be taken care by the pressure bandage, or if it is not there, then exploration has to be done. If there is increased bleeding or filling of the this thing drain, then take the patient to the OT and then explore. Do not explore on the bedside, because there is this thing, you don't have the proper instrument, there is no light, and the things if there is a compromised sterilization. So take the patient straight to the OT and explore the wound again and tie the bleeding vessel. If there is a not immediately, then there can be ecchymosis or firm palpable swelling in this. There can be clotted blood, or the flap, because of the pressure, it may be at risk, and pressure may be applied and on the airway also, and it can be this bleeding or hematoma can be life threatening also. The immediate complications could be because of nerve injury, coil leak, air embolism, if the lower slippage of the lower ligature when you are tying the lower end of the internal jugular vein. So at that site, the air may be sucked in, and that is one of the emergency in that has to be taken care when lower down the head end of the patient and put the thumb, and the assistant should not jump. It is the senior surgeon that should take care of this. And if there is a bradycardia, it could be because of injury to the vagal nerve when you are tying this, or if when one side of the internal jugular vein has been tied, there will be 3 times rise in the intracranial tension, and patient may aspirate, leading to pneumonia. These are the immediate complications which can occur. Intermediate, when it occurs after 5 to 7 days, there can be seroma, hematoma, and chyle fistula. I'll be talking separately. So the wound infection, because if there is a compromise on the or if the proper antibiotic are not given, the flap necrosis may occur because of the flaps are not properly designed, or there is a long flap, then the distal end of the skin flap that starts giving in. And if the patient has been given radiotherapy, then the chances of this carotid blowout will be there, and patient is in the lying down position, patient can have pneumonia or deep vein thrombosis. These are few of the complications. The chyle fistula, the incidence is 1.9%, and it occurs intraoperatively. So on left side, when you are tying the internal jugular vein or you are doing modified neck dissection, then you have to be aware of this. On left side, the thoracic duct comes and it enters at the angle of the subclavian vein and the internal jugular. So it is when you are clearing the subcutaneous nodes, you should be aware on the left side. Even in 20% cases, this thoracic duct is there in the right side also. So it's not only on the left side that you should be aware. If there is any fresh, watery or milky fluid in the lower part of the or just above the clavicle, you should be aware. And you sometimes we do see this thoracic duct. So it is more on the left side, and it has to be, if you had injured it, ask the anesthetist to do the Valsalva, and you have to control this. There is no compromise on this, because it will lead to the nutritional problem, and subsequently the drain will occur, drain will increase, and patient will have complication. It is one of the major complications which can occur, and patient has to be this the thoracic duct has to be repaired or closed there only. So it can occur at the intraoperative, or it can occur in the postoperative after 24 hours. If the drain in the drainage is more than 600 ml, then it is then no chance of conservative treatment. You have to take up the patient, either ligate or put some sclerosing agent. If less than that, then the conservative treatment is can be treated either with the closure of wound. You can put a sclerosing agent, or you can put some pressure dressing, or stop the this thing fat diet. So all that this conservative measures can be taken, but if it is more than 600 ml, then you take help of thoracic surgeon, and this thoracic that can be ligated either endoscopically or with the help of a lymphangiography, or with the traditional way. So this has to be treated, and you have to take the prevention is there when you are doing the primary resection. So this is, you can see the chyle there, and it is to be yes. When you have finished the operation, please ensure that the fossa above the clavicle is dry before you proceed for the closure. The nerve injury, the various nerves which can be injured are 7th, 9th, 10th, and then 7th, 10th, 11th, and 12th, and the phrenic nerve, that is 3, 4 nerve. You are asked in Viva OC what is the root supply of phrenic nerve. The sensory nerve, the lingual nerve, great auricular nerve, cervical nerve, or sensory nerve, sympathetic nerve, that leads to Horner syndrome, that is ptosis, meiosis, and anhydrosis. So when you are tying the lower end of the internal jugular vein in post-RT cases, it is the vagus nerve which is at high risk. So that is the site where you have to be extra cautious to prevent that damage to the this 10th nerve. When you are doing raising the superior flap, then Hayes-Martin maneuver has to be done to tie the facial vein and lift up it as one, so that this vein and this nerve is elevated and preserve this marginal mandibular nerve. When you are doing the submandibular gland dissection, then lingual artery, this lingual nerve comes in a picture, and you have to take care, and you have to dissect it meticulously, otherwise this lingual nerve can be damaged. When you are elevating the posterior flap, the greater auricular nerve comes, and anterior branch can be sacrificed because that goes to the parotid, and the tail of the parotid is to move, where the posterior branch is to be preserved because that gives sensation to the pinna. This sympathetic nerve and this cervical this thing, now they come in picture when you are doing the posterior triangle neck clearance, and spinal accessory nerve is already sacrificed in R&D, so this has to be preserved. Otherwise, this will lead to the bluntness on the suprascapular area, or this sympathetic chain is there just below the posterior to the or medial to the internal jugular vein. So sometimes this may be damaged, and this leads to the Horner syndrome. So vascular complication, carotid artery, this is a primary injury, has to be repaired intraoperatively. Carotid blowout occurs more in after the radiotherapy, and there is a 50% mortality. The factors which lead to carotid blowout are radiotherapy, infection, necrosis of the wound, pharyngocutaneous fistula, tumor involvement of the carotid, and rough handling of the vessel where dissecting. So if it has occurred, then it is a real emergency, and this will give a sentinel bleed will occur, and you have to take immediate factor, either tight pre-op this thing before it blowout occurs, or if it occurs, then shift the patient to OT, and you have to put a pressure and then make a fresh incision, and at the fresh side this carotid is to be tied. And in 20% cases, there is good supply from the opposite side in circle of Willis, and patient can have no neurological deficit. Otherwise, chances of stroke are there. So in this internal jugular vein, this I said, when you are tying at the lower end in the beginning, that first step which is done in neck dissection, and the pressure intracranial, there can be thrombosis, or there can be stroke and blindness. When the blindness occurs because of hypotension and the vascular, there is low perfusion, or in prolonged surgery, these are the uncommon complications. This thrombosis, again, because of mishandling or damage to the adventitia, or there is improper ligation. There can be slippage of ligature, and this air embolism, as I said, because of the slippage of the lower ligature. So There can be late complications, recurrence, parotid hypertrophy, lymphedema, scar, and these are the primary recurrence at the primary site or at the nodal site or at distant site. Then this is a small girl which I operated. You can see the hypertrophic or keloid formation scar there in the side where the neck incision was given. So with this, I finished this, and I have got a video. Do I have time to show you for Dr. Nilima? Can I
Yes,
show?
we can.
Hello?
Yes, sir, we can.
Okay. This is a neck dissection which I did, and you can see this patient has a primary, as I said, and this is the incision which is given. So this is the vertical incision, and this is the platysma. You can see. So I am dividing the platysma. You can see this is the platysma which is there, and I'm not preserving the marginal mandibular because this is anterior part of the chin is to be removed, so the lip will be involved in this case. You can see I'm just hugging the this is platysma, and now we are going down a vertical limb, and you can see this is platysma which is coming, so it is subplatysmal, and I am now trying to identify the this spinal accessory now. So it is at the level of, if you draw a horizontal line at the level of a hyoid bone posteriorly, that is the site where you find the spinal accessory now. So this fascia is held with the help this artery forceps, and this there is a counter traction given with the help of by retracting the sternocleidomastoid, and you are just peeling away all the fascia which is there on the sternocleidomastoid, so it is preserved. And you keep on dissecting it till you come across the, you reapply, and this just see the assistant is pulling from anteriorly, and I am holding pulling it from posteriorly, and we are just peeling this fascia, and this is the medial dissection which is there occurring, and with the help of cautery, so we are getting a good feed also, and usually ask the anesthetist to give a low BP. The systolic is maintained in 80s, and now you can see the internal jugular vein which is coming in picture, and this is the blood supply to sternocleidomastoid. So sternocleidomastoid gets supply from the occipital artery at the upper end, from the superior thyroid in the middle, and from the thyrocervical trunk in the lower part of the sternocleidomastoid. You can see the fascia which is now medial to this, or on the medial aspect of the sternocleidomastoid is retracted, and this I identified the spinal accessory now, and now you put a sling this, so this is retracted, and now it is spinal accessory now is retracted inferiorly, and this is level 2B dissection is going on, because this level 2 is divided into two parts by this spinal accessory. So this is we are just exposing the spinal accessory now higher up, and this the one which I am holding is the level 2B. So once you have exposed, and this is the part of the soft tissue which will be removed, is level 2B. So this is a level anterior part, and now I am freeing this from the attachment, and once this is done, now I'm holding this fibrofatty tissue with the help of Elise, and now with the retraction, here you can come across occipital artery, and that is the source of bleeding, so you should be prepared for that, and this part is what is level 2B, and you have to dissect it out until you see the these paraspinal muscles which are coming into picture. You can see there, and so you'll these are the muscles, and this is a small piece of this thing, in some of the centers, this level 2B is not removed unless you do level 2A, and if it is positive, then you go for level 2B. But in our center, we don't have facility for frozen section, so we routinely move to level 2B also in all the cases. So this is takes another extra 15-20 minutes to remove this, and we don't take any chance. So now is retracted entirely so this is the specimen which is removed, and now further down this is we are carrying out, and we are coming across this rootlets. Once you come across this horizon and this cervical roots, that is the site when you turn medially. Till now, I was going down posteriorly, and once we see this cervical roots, that is the level where we turn medially and then start dissecting anteriorly. So this is the belly of omohyoid muscle, which is dissected out, and now it will be held and retracted upward, and we are again proceeding towards the anterior dissection. Now this internal jugular vein is coming into picture, and now I am feeling this now the carotid sheath is dissected out, and the assistant pulls the thing anteriorly or towards himself, and I'll be just putting a gauze piece on it and pushing it posteriorly, and this is one of the mid-thyroid vein which has come into this thing, and it will be tied. So you have to be extra cautious and gentle when you are dissecting out. There is no posterior tributary. That is the peculiarity of this internal jugular. All the tributaries to the internal jugular vein are anteriorly placed. So you put a ligature because this is very fragile, and you have to be very cautious and gentle when you are handling the internal jugular vein. So these are the muscles, lymph nodes, or that specimen which is resected, and it will be after freeing this internal jugular vein, the dissection will proceed further up, and this is the submandibular gland area or the superior part. And once this, you have to dissect out, or you have is very fragile, and you may, if you are not concentrating properly, you may damage it, and you may have to take help of plastic people to repair. I'm doing this modified neck dissection routinely because in majority of the cases the free flap are done with the help of plastic people. Now you can see this carotid has come in picture, and now this internal jugular vein is almost clear, and now the dissection is from below upward, and all the fascia which is there in the anterior triangle is removed, and this is the thyroid, and now this is the muscle which is held is omohyoid, and up to the anterior valley of sternohyoid, all this fascia which is over the muscles is removed, and this is one of, there is no fixed pattern of the vein which is there, so only internal jugular vein, and sometimes you have another veins. Now I'm this specimen is cut short in size, and we just level 4 is separated from the cricoid to the suprasternal notch, and now this is level 3 is being separated from the cricoid to the hyoid bone. So we are after separating, you are putting in separate this thing, these specimen are put in different separate bulb, and which are labeled by the sister or the circulating sister, and we tell that which node are put in, or we are giving which level of the lymph node. Now this is submandibular gland which is there, and all the levels 3 and 4 have been separated and they are handed over to sister, and now we are dealing with the 2B has been removed, and now we are dealing with the 2A group of lymph node, that is submandibular this thing, and at the end this anterior digastric or submental group will be dealt separately. Now we are now I'm dissecting this is angular vein, or this this is a branch of the facial vein which is there, so it will be a big stump is left for, that is for the anosmosis, which will be, I'll be just dissecting it out. So this is submandibular gland dissection is carried out, and this is the side where you open, you have to retract and separate, and this lingual now will come in picture. This is the just now you saw the white band, that was the common tendon of the diaphragm. These are perifacial node which you have to remove separately, and now this is the facial artery which was preserved, because that is the artery usually taken by the reconstructive team, and now I am dissecting out the gland from the in between. So that finishes my presentation. Now I would like to take the questions.
Thank you very much, Dr. Ishwar, for your presentation, and thank you very much, Dr. Nilima, for joining us. And thank you, students, for joining us. Good night.
No questions?
I can't see the chat box, Mr.